Good afternoon, everyone, and thank you for joining us for today's webinar, Seeing the Future, Medical, Ethical, and Financial Considerations of Hepatitis C Transplant. Now, before we get started, my name is Deanna Fenton, Program Manager here at the Alliance, and I'd like to take the next few minutes to sharing a few reminders with you all. As always, it is highly recommended that you access our webinars using the Chrome browser in order to ensure an optimal visual and audio experience. If you're already using Chrome and are still experiencing issues, please try connecting to the webinar using the phone number that was provided in your confirmation email. And to anyone who's joining us for the very first time today, please take note of the chat feature that's located in the bottom left-hand corner of your screen. This chat will be used to pose questions to our speakers, so if you have any questions that come up during the course of the webinar, please feel free to submit them at any time. Once the presentation has concluded, we'll have some time for our presenter to address as many of your questions as time allows. Now, for anyone interested in our upcoming webinars, we are hosting our final webinar of 2019 on donor heart preservation in the 21st century. This special bonus webinar will be brought to you on November 26th at 3 p.m. Eastern. Anyone interested in joining us for this webinar can register on our website. And additionally, you can take a look at a few of our upcoming 2020 webinars that are currently open for registration. So for more information on this webinar or our upcoming webinars, or to register, please visit organdonationalliance.org. Now, for anyone interested in continuing education credits, we are offering one CET-C credit and one nursing contact hour for this webinar. Please note we do also offer a certificate of attendance for anyone seeking CEs that are not available. Everyone joining us today is eligible to claim either of these credits or certificates. Prior to receiving your certificate, you will be asked to complete a brief online evaluation that will allow you the opportunity to provide us with your valuable feedback. If you're listening in a group, as many of you are, please be sure to get the evaluation email from your group lead. As a friendly reminder, for nursing, you'll have 14 calendar days to complete your evaluations and claim your credits, and for CEP-C, you'll have 30 calendar days. Now, at this point in time, I'd like to introduce our moderator, Dr. Randy Sung, Professor of Surgery at the University of Michigan. Randy, thank you so much for joining us today, and at this point, I'll go ahead and turn it over to you to introduce our presenter.
Thanks, Deanna, and welcome, everyone. It's my pleasure to introduce today's speaker. David Goldberg is an Associate Professor of Medicine at the University of Miami Miller School of Medicine in Miami. Dr. Goldberg is a transplant hepatologist who performs epidemiologic and health services research in the field of chronic liver disease, organ transplantation, and organ donation. Along with Dr. Peter Reese, he co-led the THINKER, USHER, and SHELTER trials, which were pilot studies focused on transplanting organs from HCV-infected donors into HCV-negative recipients, which is a very emerging source of donor organs, and that's what Dr. Goldberg is going to speak about today. So welcome.
Thank you very much for the introduction, Randy, and thank you to the moderators and for the Organ Donation Alliance for giving me the opportunity. So the title of my talk is Seeing the Future, Medical, Ethical, and Financial Considerations of Hepatitis C Transplants. So I do obviously have disclosures that I think are important to acknowledge. So I will be discussing research funded by investigator-initiated grants paid to the University of Pennsylvania, where I was previously employed. I have received research funding from an investigator-initiated grant paid to Penn related to hepatitis C. I am the co-PI of an NIH U34 grant, which is focused on developing a multi-center we call THINKER Next kidney trial, and I will be discussing the use of a laboratory-derived test for hepatitis C genotype. So the outline, I just want to review the basics of hepatitis C serologies, the timeline of hepatitis C testing and organ donation, briefly the evolution of treatment, the use of hepatitis C-positive organs, the landscape of these organs, whether this is trials versus practice, how one does it, and the THINKER trial and preliminary data. So just to sort of start at a basic level, hepatitis C is an RNA virus. It is passed by blood-to-blood contact. Acute hepatitis C rarely causes symptoms, but when it does, it can cause a flu-like illness, exceedingly rarely a severe presentation. So unlike things like hepatitis A or hepatitis B, where patients can get liver failure acutely, it's, case reports out of the millions of people who've ever become acutely infected developing liver failure. It is thought of as a chronic infection that can lead to cirrhosis and liver failure. But unlike viruses that we routinely encounter in transplant, CMV, EBV, HIV, hepatitis C is curable, and the cure is long-term in their studies following people out more than 20 years that when you're cured of hepatitis C, you are cured. So the epidemiology, so the infectivity when you're acutely infected is such that 2/3 will become chronically infected and 1/3 will spontaneously clear the infection. So not everyone who has an antibody for hepatitis C is currently actively infected. When you spontaneously clear the infection, there are no reservoirs of hepatitis C. This is distinct from hepatitis B, where someone is said to clear the infection, but they still have a few viral particles living there. About 1 to 1.5% of the overall U.S. population is infected, about 1 in 30 baby boomers, and it's estimated that 3 to 5 million Americans are infected, although the exact numbers are unknown. So how we treat hepatitis C, I'm young in my career, and I've already seen a sort of rapid evolution. So pre-2011, we would treat patients with interferon and ribavirin and get cure rates of 30 to 40%, and highly selected patients who did not tolerate their therapy very well. There was a brief period of time where we used interferon with a drug called telaprevir or boceprevir. Our cure rates went up a little bit, but our side effects got even worse. Since 2014, though, we have used all oral regimens, and I'm not going to go through all the specifics, but they all have over 95% cure rates for hepatitis C. And by cure, it means that 12 weeks after stopping therapy, you have no virus detectable in your blood, or what we call SVR12. Cure rates in large trials are similar pre versus post-transplant. The treatments, the sort of nuances of treatment vary based on genotype, renal function, liver function, and as financial considerations was part of this title of this talk, they are still costly. And although the prices have dropped, the least expensive regimen is still about $25,000. So it's important to understand hepatitis C serologies because I think there's still many people in the transplant community that don't really understand. So hepatitis C antibody means that there's previous exposure or infection, whereas nucleic acid means that there's active virus in the blood. If both of those are negative, the person has never been exposed or they're in the window period and haven't yet developed a detectable level. There are a number of donors that are antibody positive but nucleic acid negative, which have been, I think, misunderstood for a long time as being thought of as hepatitis C infected donors. These donors could have a false positive antibody, an active infection with low-level virus. They're on treatment, or they've been treated before, or they have spontaneous clearance. And this is important because about 1/3 of donors that have been deemed hepatitis C positive donors only had a positive antibody, had no virus, and don't have the infection. They still could pass or develop hepatitis C during the window period, but the antibody really does not mean anything about their current level of infectivity. And NAT positive means that there's an active infection. So the evolution of hepatitis C donor testing, so we started using the term CDC high risk in 2004. Donor NAT testing was variable until February of 2014 when it became mandatory to test all donors, and it was not until 2015 that we started collecting these through the OPTN UNOS registry. So prior to 2015, any studies looking at registry data talking about hepatitis C positive donors could not delineate between antibody positive and NAT positive. So in terms of the utilization, like I said, hepatitis C positive pre-2015 is a misleading term. If we think about viremic donors, there was high utilization for livers because we had hepatitis C as the leading cause of liver failure requiring a transplant. Kidneys, as we published, about 2/3 were discarded. Lungs and hearts, there was near universal discards. Antibody positive, NAT negative, until papers started coming out in 2016 and 2017, were treated like NAT positive even though they were not. And in terms of treatment, liver cure rates were one of the major issues because when we used interferon, we had very poor tolerability, poor cure rates, and a lot of side effects in post-transplant patients. And I see that this is a hand raise. Is that everyone hears me okay? I'm assuming that's a yes. So the unfortunate reason, why I'm giving this talk is the opioid epidemic and the drug overdose epidemic that we're seeing in our country. And these are data that, I see someone saying there's no sound. Is there no sound?
Dr. Goldberg, we can hear you. We'll take care of the...
Okay, sorry. Okay. So these are data that we recently published in Clinical Transplantation, but we obviously know that this issue of hepatitis C-related donors is a byproduct of the drug epidemic in our country. And when we look at drug-related deaths among deceased donors, and we define drug-related in this paper as either having a mechanism of death of a drug intoxication or another mechanism and have active IV or non-IV drug use, we see that the numbers are sort of increased fivefold over the last almost 20 years to 5,000 donors last year who drugs were sort of part of the reason why they died and became a donor. So we sort of identified an opportunity in 2015 to potentially transplant organs from hepatitis C-infected donors, and we published this prospectus piece in the New England Journal of Medicine where we looked over a 10-year period and found that there were 2,500 donors where at least one of the kidneys was discarded, which could have led to anywhere from, depending on the time period, anywhere from 2,000 to 10,000 years of survival over a 5-year time period were they used. Now, one thing to Mark sort of fast forward a little bit is there have been increased utilization of hepatitis C viremic donors, and that's what I'm going to be focusing on. Viremic meaning the NAT is positive, but we still see that there are many of these organs that are not transplanted. And this is a focus of kidneys, and it's fast forwarding, but to show that even though we've heard a lot about increased utilization of them, 40% of kidneys from hep C viremic donors are not transplanted. So we have also been underestimating the supply of potential donors as a transplant community because of how we sort of collect and define a donor. So a donor is defined by UNOS as a patient whose organs are recovered with the intent to transplant. But there's many people that are excluded by this definition. Potential donors without authorization, the person is not registered, the family says no. A potential DCD donor that's not considered for donation because of low utilization. A single organ donor, or donors who were never referred. Potentially, the local hospital thinks that the organ may not be used. And we actually looked at this. We collected data from 6 OPOs, and what we found is that of 440 consented NAT positive, so viremic potential deceased donors, about 27%, or about a quarter of them, never had an organ recovered, so never would have been considered a donor by how we currently measure it. So in terms of the underutilization of hep C donors, we are underestimating the utilization. If we use the UNOS discard rate of only counting a donor where at least one organ is recovered, we're at about 50%. But if you actually include this broader number, it's about 2/3 that are still being discarded. Now, why were the hep C positive donors discarded so frequently, and specifically in kidney? So for kidney, there were a small number of people on the waiting list for these organs. Patients or centers did not want to use these organs. And there was this data that was provided by UNOS several years ago that although about 5% of waitlisted patients on dialysis have hepatitis C, only 2% of patients on the wait list would opt in for them. There were concerns about the risk of other infections. These patients may have current or active IV drug use, and they also have been thought about being of lower quality. And I'm sorry that it comes out like this. I forgot when I was doing this that I don't have animations. But what this slide was meant to show is the KDPI helps or unfortunately hurts to make these organs look worse than they might be, because the KDPI gives a bump for hepatitis C, because historically we were using these organs in people with hepatitis C and chronic liver disease. Kidneys from donors with hepatitis C get a higher score, and people may think that they're of lower quality, although emerging data from our group and others shows that they are actually better than they would be measured otherwise by their KDPI. So I want to sort of go through the body of literature that we have available to us now. So there's published data from clinical trials or center case series. And I think one of the things is that there's no sort of registry of hepatitis C viremic transplantation to Hep C negative in the context of outcomes beyond graft and patient survival. In the OPTN registry, there's data on the donor viremic status. There's no data on the recipient viremic status, only the antibody. And other than graft survival, patient survival, and some renal function data, it doesn't capture outcomes like hepatitis C cure, complications of therapy. But in terms of thinking about what is sort of out there in terms of practices, there's sort of three ways to think about how people have been doing them. There's ways to treat people what's called prophylactic, or where you treat the person on call to the OR or at the time of transplant. The benefits of this therapy is that approach is that it could shorten therapy and prevent infection, and we'll go into some of the data about this. The sort of risk is that there's limited data on enteral administration, and none of the current hepatitis C therapies are labeled to be crushed and put down an NG tube, and it's less real world because of the ability to actually get drugs on hand for a patient before they're actively infected in a real world setting. There's preemptive, sort of early after transplant, when we've been doing at Penn in our studies. We would treat people on day 3. The benefits of that, you could confirm infection is actually occurred, and the patient is more stable, but any delay in therapy leads to a risk of an acute hepatitis or potentially some unintended immunologic complications. And a reactive approach is when infection is confirmed and insurance approves it. The benefits of that, this relies on insurance. This is more real world and the patient is stable. But the risks are insurance delays or denials, and the most feared complication from a liver standpoint of FCH or fibrosing cholestatic hepatitis C, which is just very aggressive hepatitis C. As it pertains to how we are practicing here, we require, if you're giving prophylactic or preemptive approach, you either require donated drug, a drug company donates it, or a hospital provision of drug, because to date, I'm unaware of any insurance company approving hepatitis C therapy prior to transplant for someone who's not infected. Thus, to provide the drug right away, you have to have the drug in hand somehow. And that's an important thing to consider when you're thinking of clinical trials versus real world practice. So in terms of, and I'm going to go through a lot of studies here. I'm not going through every study that's been published, but the vast majority. So in terms of prophylactic kidney, so treating the patient who's going to get a kidney transplant prior to the OR or right at the time of OR, there really have been 2 studies that have been sort of presented or published. So the first was the Expander study from Johns Hopkins that was published in Annals of Internal Medicine in 2018. They gave the first dose of hepatitis C therapy on call to the OR, and like the Thinker study, because these were investigator-initiated studies funded by Merck, they used Grazoprevir Elbasvir, which is called Zepatier. And the goal of this was to prevent infection. In their study, 10 out of 10 were cured, so 100% cure rate. 5 out of 10 had no evidence of true infection, but the caveat being they tested on day 1. So if someone got a transplant on Monday, their hepatitis C level was checked on Tuesday. It could have been 24 hours later, and it's possible that they did have infection in the interim that we couldn't detect because of the timing. There were no liver or renal complications. At the liver meeting, the group from Hopkins presented their abstract, their study, RIANA, where they did 4 weeks of treatment. This time they were using the drug Gocapravir Preventacir or Mavorad from AbbVie, and they gave a 4-week course of therapy, and 9 out of 10 were cured to date, and the 10th person just had not reached the time point. In terms of another study about prophylactic kidney, and this is one that sort of I think has raised some caution in the community, there was a study published in the American Journal of Transplantation from the group at VCU, where they did what they called ultra-short therapy, and they did this in 2 phases. The first phase was a pilot where they gave patients 1 dose of Hep C therapy before transplant and 1 day post. The second phase, based on their results, where they gave 1 dose pre and 3 doses post. And the hope was that by really shortening therapy, you could lead to cost savings by not requiring all these patients to require long-term 12 weeks of therapy or full course therapy. What they found is that the first group of those that just got 2 doses, 3 of 10 required full course therapy, which is what led them to extend the therapy in the second phase. In the second phase, 3 out of 40 required full course therapy. So on the plus side, they did 50 transplants, and 44 out of 50 people only required a few days of therapy, which is the positive. The negative, though, is of the 6 that required full course therapy. So 6 ended up requiring full course therapy. Of those 6, 3 were cured with that first-line therapy, the 12-week regimen. 3 failed the first-line therapy and required second-line therapy. 2 of the 3 that got the second-line therapy were cured, but one of them has subsequently failed 2 rounds of therapy. And a presentation that I've seen, and I'm not sure of all the specifics, but the patient had then developed multiple mutations, and it seemed unclear whether there were any treatment options available. Preemptive kidney is the approach that we took at Penn for the Thinker studies, and the first cohort was 10 transplants, the second cohort was 20, and this is extended. This was a study where we treated on day 3 with grisoprovir and elbasvir, or Zepatier, and this is where we had the laboratory-derived test where we would genotype the donor and only use donors with genotype 1 or 4. The reason for this was because when we started the trial, this drug, grisoprovir elbasvir, was the only one approved in the setting of renal failure, but it did have a restriction on genotypes. We published this that the first 20 were cured with first-line therapy, and as I'll show later on, 39 of the first 40 were cured with first-line therapy. 1 person failed first-line and did require second-line. There were no liver-related complications, and there's excellent renal function in patients who are now over 3 years out from transplant. One of the things as I get into the KDPI that we had published on was we looked at the KDPI that was measured for our hepatitis C donors, and then we said, well, how did those kidneys perform to kidneys from donors with the same KDPI? And that would be in the sort of bluish purple in the middle. And what we found is that the hepatitis C viremic kidneys did better than one would have expected for KDPI. In the pink to the far right on both the 6 and 12 month, we actually showed that if you got rid of the KDPI points for hepatitis C, the kidneys did as expected. So if you have a kidney from a hepatitis C viremic donor with a KDPI of 50, it actually behaved more like a KDPI of 30 in terms of outcomes. So we were sort of grading these kidneys as worse quality than they actually are by virtue of the use of older data from the KDPI that included hepatitis C recipients. A reactive kidney approach, and the largest published to date, was from the Methodist group in Tennessee, where it was a standard of care approach. And they published their study in the American Journal of Transplantation, where they sort of reached out and sent a letter to all patients to notify them that they would be switching them, and they had to send back a signed consent form saying they were agreeable to this. They published data on 53 kidney transplants, and what was interesting and different than the Hopkins and Penn studies is that the median time from transplant to treatment initiation was 76 days, or about 2.5 months. All patients became viremic, so again, we're seeing this that if you transplant an organ with hepatitis C, the person develops it. What was interesting is that 20% of their patients had significant increases in their aminotransferase levels. Again, there was a delay in therapy. One patient developed fibrosing cholestatic hepatitis C. Despite all of that, they did have 100% cure rates, which was great, but they did have unexpected complications that it's unclear if this is due to delays in therapy and some immunologic upregulation, but about 60% of their recipients had CMV viremia, whereas normally you expect that number to be about 20%, give or take, and 32% developed BK viremia, much higher than you'd expect otherwise. Switching above the diaphragm to the thoracic world, there have been several trials published on the thoracic. The 2 groups in Boston, the Brigham and Women's group and the Mass General group, have each published separate studies of prophylactic transplantation. The Brigham and Women's group, which was published in the New England Journal of Medicine, was both lungs and hearts, and they published data on 44 transplants, all of whom were cured with 4 weeks of therapy. This is called prophylactic, but unlike the study at Mass General or Hopkins where they gave it before the OR, at the Brigham and Women's they gave it immediately post-op, and they did give a short course of therapy of 4 weeks rather than 8 weeks and still had 100% cure rates. The Mass General group did a study where they looked at 25 heart transplant recipients who got 8 weeks of therapy on call to the OR, and they were all cured. So both a reactive and a preemptive lung was tried at Toronto General. And I want to thank Jordan Feld for sharing some of this data with me. So they had 2 studies that were somewhat different but very interesting. So in Toronto, they've done a lot of work in this EVLP, or ex vivo lung perfusion. And one of the goals was to see if they could prevent transmission of hepatitis C by using ex vivo lung perfusion to sort of flush the lungs, but then based on data they published in Nature Communications to actually apply UV light to the perfusate to help inactivate the hepatitis C. And I'm sorry that it says Brigham here, but they did 22 lung transplants where they did put the lungs on EVLP and applied UV light, and 2 out of 22, so 11%, were actually non-transmissions of hepatitis C. So due to the flushing and the UV light, they were able to inactivate and flush out the hepatitis C. They did a reactive approach, though, where they treated once people became viremic and stable. And what was notable is that of the 20 that developed viremia, 2 out of 20 had fibrosing cholestatic hepatitis C and required second treatment. Both were cured, but one of those people was quite ill. The second study, which was just published at the liver meeting, was an all-organ at the Toronto General, where they did EVLP and UV light, but they also treated patients with ezetimibe, Azedia, which is a cholesterol medication that there's some data that it may actually block entry of hepatitis C into hepatocytes, and they only gave a 1-week course of therapy. Despite that, they were able to get 100% cure rates, and in their thoracic recipients, they were all treated and done with treatment by the time they were discharged from the hospital. And this is just a study showing the sort of premise of the Toronto General. And just to see on the left, you see the hepatitis C with the UV control. And then you see on the right where they were able to inactivate it and drop the activity of the hepatitis C by applying UV light. A preemptive approach, at Penn we published the USHER study where, again, similar to Thinker, we did day 3 treatment with grisopavir and elbasvir for genotype 1 or 4 hepatitis C. We did 10 heart transplants, 9 of 10 were cured. 1 patient did die prior to SPR12 but had an end-of-treatment response. There were no heart-related issues, and 3 of the patients did require enteral administration of the hepatitis C therapy. And then a reactive heart. The Vanderbilt group had the first published heart study where they initially did 10 transplants and 9 out of 10 were cured. And this has been extended to more than 50 transplants where they would do an approach of applying to insurance to get the approval. The University of California in San Diego published their data of 19 transplants, and all were cured without any heart-related complications. So this is sort of the sort of clinical experience based on formal trials or case series of treatment. But there's other things that have been elucidated through these different studies. So one of the things that we had published on at Penn in our USHER study was that, first off, we did publish about one of our treatment failures, but also we had 5 cases where the donor donated both a kidney and a heart to patients at Penn. And what you see in these 5 figures is that the viral load started lower and dropped faster in the heart recipient in 4 out of 5 cases. The thought behind this was that there may be a sort of different viral inoculum, but it was very interesting to see that the heart recipients invariably from the same donor had a lower viral load to start and a more rapid clearance of the virus. And in the one case, donor 5, where we had a kidney patient that failed therapy, the heart patient who got the same donor actually had rapid viral clearance and had no issues despite the fact that they got the same virus from the same donor. Another thing that's interesting, and I will admit, this is probably the only time I'll get a basic science paper in a journal like this, so I wanted to show it. But one of the things that we had talked with one of our virologists was the whole issue of the viral transmission bottleneck. So what had been known from literature of blood transmissions of hepatitis C was that while a donor, quote unquote, the person sharing a needle, may have had 20 different quasi-species of a hepatitis C, the person who would get that hepatitis C would only get 1 or 2. But what we saw in our patients, and we studied this sort of deep sequencing of the virus in a few patients, is that you see in the pictures on the right under B, is that unlike sort of blood-to-blood transmission where only one virus predominates, we saw almost all of the species of hepatitis C that were in the donor and the recipient, showing that there was a very highly permissive transmission process. The last thing that we had looked at is that we noted that a lot of our recipients were developing hepatitis C antibodies, and there were people reporting that they were getting hepatitis C transmissions based on an antibody. And what we found is that in 40 transplants, both heart and kidney, 18 out of 40, or 45% of our recipients developed a hepatitis C antibody. But what was interesting, and I think helped elucidate the mechanism, is that they were all IgG, meaning that they were not developed by the recipient right away. These were day one where an IgG can't form. Some of them persisted out beyond 100 days. So it suggested that there was passive transfer of antibody from the donor to the recipient, and or it might have been also transmission of things like plasma cells that would then actually be producing those antibodies. Other things that have come out from studies, and I give credit to Emily Blumberg, who shared this slide with me, but while the outcomes are good, it's not all rosy. Now, these studies did not have necessarily appropriate comparators, were not controlled studies, and didn't match for a comparator group. But in many of the studies that have been published, there were rejection rates that were higher than we might have expected. In this study from New England Journal of Medicine from the group of Brigham and Women's, their heart recipients stayed 55% that had acute cellular rejection and 61% of their lung. Now, again, we can't make conclusions based on these small numbers, but it's a signal that there perhaps might be some immunologic consequences to infecting someone with hepatitis C. Beyond that, there are also viral complications. So there have been treatment failures. Now, we know cure rates in the general population are about 98%, but there have been failures. I mentioned the one at Penn, Toronto, where they had 2 in the VCU experience. There have been cases of fibrosing cholestatic hepatitis C, the most sort of dreaded type of hepatitis C, and there have been other viral complications. Mayo Jacksonville published a case report of a recipient who got hepatitis C, a liver recipient, and then developed an acute membranoproliferative glomerular nephritis with renal failure, got treatment, renal function improved but not fully, and they actually presented at the liver meeting that that recipient actually died about a year post-transplant when they developed recurrent renal failure. And I mentioned the CMV and BK for Methodist. So what do we know based on available data? So transmission is universal from viremic donors. There have been some reports of non-transmission, but one of the thoughts is that these might have been false positive NATs from the donors, because essentially everything that has been confirmed is that transmission is universal. We know that the donor viral load correlates with the recipient viral load. So when a donor has a very high viral load, the recipient will get a higher viral load early on. The cure rates are similar to chronically infected. So I think from what we've seen, now again, we don't know what hasn't been published because there's no data registry, but it seems as if cure rates are similar. There's a potential for short course therapy. We've seen as short as 1 week from the group in Toronto, but there may be a limit, as we saw from the data from VCU. We know that more organs are being utilized to save more lives. We also know there's variable practice across the U.S., whether it's a trial or standard of care. I think one of the concerning things we unfortunately know is that insurance approval is not universal. And we know the short-term impacts on the graft are minimal. But now, what do we not know? So what are the true cure rates? As I said, we don't know the true cure rates because there's no registry. What people have published has been encouraging, but we cannot say for sure. What is the informed consent process like for patients? Again, there's no specific policy or oversight that says what the informed consent process must say. We don't know how many other viral complications are there. I give credit to those centers that have published the sort of negative outcomes of patients, but we don't know the full extent of it because, again, it's not published. One of the things that patients ask me is, well, I'm getting a kidney. How is hepatitis C transmitted? We don't know. What are the long-term impacts to the graft? As I said, the Thinker study, we have patients beyond 3 years, and we are writing up those data. But again, it's a small number. What are the true risks of the other viral infections, specifically the CMV and the BK? We don't know. What is the optimal time course? So one of the questions, of course, is the benefit of short course therapy is that you're saving money, but what are the risks? And does it matter if therapy starts late? I think that question is still up in the air. So how should this be done currently? So I think it depends who you ask, and it depends on the organ. I think liver is a little bit less controversial because we know that those are organs that are infected, and I think everyone would agree that they should get full course therapy. My own personal opinion, I think that the ideal scenario is that this should be an IRB-approved research protocol, where the practice and protocol is vetted for patient safety and proper informed consent. I think there should be evaluation for higher risk features like liver disease, especially in the setting of kidney transplantation, where patients may have undiagnosed fatty liver disease and even hepatic fibrosis, which you may not know about. I think a reasonable alternative is that there's a formal education and informed consent process, the appropriate patient selection, that there is some pre-transplant assessment of liver disease. Again, I think there should be a fiber scan or something beyond just looking at liver tests. And there has to be guaranteed drug coverage, and that is that the insurance is pre-authorized, or if not, the hospital or health system offers some sort of safety net. And I do think treatment should be with either Epclusa or Mavorite. Epclusa was a drug, sofosbuvir, valpatisvir, from Gilead, which there had been historical concerns about use in renal failure, but a labeling change last week has made that obsolete. So what are some considerations in patient selection? So do we need to screen patients for pre-existing liver disease? So all of the clinical trials, Thinker, Expander, the Toronto experience, has been yes. There are risks of undiagnosed liver disease, especially in renal patients. What are the risks of infecting people with pre-existing liver disease? We don't know. Are the risks magnified if reactive treatment approach is applied? I personally fear giving someone hepatitis C if they could have stage 2 NASH fibrosis and waiting a month to treat their hepatitis C. What if they require enteral administration? So there's limited published data. The group at Brigham, Toronto, us, and Mass General have used crushing of pills, but again, it is off-label. What if patients are on amiodarone? Because there's issues if you do a heart transplantation or if they need amiodarone and sofosbuvir. What if they have prolonged hyperbilirubinemia? And I think the big thing as a financial and sort of ethical is what if there's insurance denials or delays, is what are you going to do? Because I think it's highly unethical to not have a backstop and then leave someone in a position where they can't afford the drug, insurance is saying no, and then they develop complications of hepatitis C. So what are the financial and logistical barriers? So unfortunately, I think at the last liver meeting, Jordan Feld from Canada and the other moderator from Australia sort of made fun of us in America, but this is true. We don't have universal health care. Different people have different health insurance, and we can't guarantee therapy for everyone. Who will pay for therapy? So if there's prophylactic treatment, so on call to the OR, there has to be some hospital coverage. Then there obviously are implications because if you treat someone on call to the OR, they never get a detectable viral load. Will insurance approve it? You need some sort of universal insurance approval. Hospitals could consider stocking this on the formulary, but it depends on the medication because some of them have daily dose wallets or blister packaging, which can become an issue for inpatient pharmacies. There are many states that have fibrosis restrictions with their Medicaid, so the concern is are we sort of not giving access to patients with Medicaid because it's a concern they won't get drug approved. DAs are not FDA approved for acute hepatitis C, so theoretically an insurance can deny it for that. And if you want perioperative treatment initiation and the hospital won't pay, then you need some sort of mechanism to get pre-approval for hep C therapy from the insurance approval. Currently, all anecdotes suggest insurance will not approve therapy until the patient has been infected. Some require documentation of infection. Some will allow for donor data, and some will outright refuse. So in conclusion, and I left time because I think there might be questions or hope. So transplanting organs from hepatitis C viremic donors into hepatitis C negative patients is an important mechanism to save more lives, increase the number of transplants, and improve utilization of a scarce resource. Highly potent DAAs should change how we rethink about hepatitis C in the setting of transplantation, similar to hepatitis B, although I think more data are needed. Informed consent process is critical, and we need to define the operational factors for broader utilization, insurers, patient selection, and unexpected risks. And with that, I want to acknowledge all of my collaborators, especially Peter Reese, my collaborator and close friend from Penn, who he and I sort of spent many, many hours developing this. Okay?
All right. Thank you, Dr. Goldberg. We're now going to open up the floor for questions, but before I go ahead and turn it back to Dr. Sung to facilitate the Q&A discussion, I'd just like to remind everyone that if you do have any questions for Dr. Goldberg, please be sure to submit them using the chat feature. Again, the button is going to be located at the bottom left-hand side of your screen. Also, during the Q&A session, I'll have this poll up for all of you. So for those of you that are listening in a group, if you could please just complete this poll and let us know how many people are participating in your group, that would be greatly appreciated. So with that being said, I'll go ahead and turn it back to Dr. Song.
Thanks, David. That was very, very comprehensive, and I think the entire group probably learned quite a bit. Thank you for your insights. So we'll get to some questions. The first question is, were the patients with fibrosing cholestatic hepatitis also on high-dose steroids at the time of treatment?
So, the data on their actual steroid dose is not put in there. To my understanding, they were all people that were well beyond a month after transplant and had been tapered down, but I don't know offhand their exact steroid dose.
Okay, thank you. While we're waiting for other questions, I have a couple. You kind of implied how you think this ought to be done. One of the questions that comes up is whether or not this should be considered standard of care. And I guess what I was interested in asking you is that should regardless of whether they do it under a research protocol or, with careful informed consent and the other provisions that you mentioned, should every center be trying to do this, or are there certain types of resources required for a center to start a program like this?
So that's a good question. Again, and I will admit that I am somewhat biased. I spent years doing this as research, and I still think it's research because I think there's a lot of unknowns. I think the challenge in terms of should all centers be doing it, I think it really depends on how your staffing model is like. So I think, there's some centers, maybe a kidney-only center that doesn't have a hepatologist. And I think you really should have a hepatologist on board. So I think if you're a center that doesn't have hepatology expertise, you shouldn't be doing. The other challenge is if you're not, so, I was doing this as, at Penn, we were doing it as research. We had research funding. It took a lot of hours to review patients' charts to determine if they were eligible to speak with them and consent them. Thankfully, I had salary support coverage for the research. If you don't, it's then the question of who's going to see the patients. If you're going to properly screen them and properly consent them, who's going to evaluate them, who's going to manage their treatment. There's a lot of time that's not necessarily billable. If your program is willing to sort of, protect someone's time to do that, I think that's okay. But I think you have to make sure you have the right staffing, because I think truly getting informed consent and truly educating patients about this is not so simple. And I think it takes time, and you have to think about how you're going to manage that time.
Great. Another question, can you explain the unique viral bottleneck again? It sounded like some protection, so maybe you could sort of run through the difference between the IV route and the organ route.
So as best as I understand it, I was the middle author on that. So normally it actually sort of is potentially not protective. So what we know is that in the setting of transmission through blood transfusions or IV needle sticks, if a donor, quote unquote, has 20, species, the recipient will only get one. In the setting of here, there is no bottleneck. So unlike the bottleneck from blood to blood, there is no bottleneck that we see in the setting of organ transplantation, which one could argue could potentially be actually worse. If there are resistant strains of virus that the donor has that gets transmitted to the recipient. Now, we think and hope that that's not the case. It's not like HIV where there's people running around with highly mutant viruses, but that's always the potential that by not having the bottleneck in organ transplantation, you could transmit that sort of more lethal virus.
Okay, great. Thank you. Who does the informed consent in your program, or I guess in other programs? Is it hepatology so that there can be a discussion of the potential consequences of HCV and also the treatment, or is it somebody else?
So, and I could give you sort of two examples. So when I was at Penn, it was either myself or Peter Reese, the nephrologist, that were doing this. We were the ones consenting the people. Early on, I was the one doing most of them because Dr. Reese is a nephrologist, had to learn more about the hepatitis C. But invariably, I ended up seeing most of them because we had to do a fiber scan, and as a hepatologist, I did it. At Miami, where I am now, where they're sort of doing it as a sort of hybrid approach, where it's not a formal clinical trial, but there's a formal consent process and all of that, almost everyone is seeing the hepatologist to ensure that they have no hepatic risks, and to sort of go over the complications. I don't think it has to be a hepatologist necessarily. Infectious disease doctors can do this. And there are some nephrologists that obviously do this, that treat hepatitis C as well. I just think that, and I shouldn't have said hepatologist, if your center has an ID doctor that is comfortable treating hepatitis C, I think that is also sufficient. It doesn't necessarily have to be a hepatologist.
Great. So I have two sort of financial related questions. So one is that you did mention pre-authorization by insurance. So if you are engaging in a reactive approach, is it possible, and in fact, is it most common to either negotiate or contract with insurers in advance to get some assurance of pre-authorization once once the transmission is confirmed, or is it more common when there have been refusals that the refusals happen after after the infection, as opposed to knowing in advance that the insurance company, a patient's particular insurance is not going to cover it, and then you don't do the transplant at all to start with?
To be honest, I didn't have to deal with this at Penn because we were all doing it as part of a trial, but sort of obviously spoken to many people about this, and actually colleagues at every place said they've uniformly, when they called the insurance company prior to transplant, the insurance company said no, that they would not approve it ahead of time. Now, what some places would do is they would run someone's insurance prescription plan and formulary to see if hepatitis C was on it, but they would not formally approve it until the person was infected. Colleagues have told me they still had to do a lot of peer-to-peers, but I'm not aware of insurance ever saying yes ahead of time.
Okay.
And I think one of the concerns that have been sort of spoken about sort of anecdotally is that some places have restricted these not to Medicaid patients if they are practicing in a Medicaid-restricted state.
Mm-hmm. Right. Okay. So it really requires a lot of advanced work, some trust that the patient's insurance is going to cover it once the infection is documented, and then I guess a safety net. Does that sound reasonable?
Exactly.
Yeah. Okay. And then if you're doing it either prophylactically or preemptively, have most groups that have done that been self-funded, or have they also been able to do it through grants? I imagine as it becomes more common, the grant money will be less available, of course.
So Johns Hopkins, the first study, Expander, was through a grant. The Rihanna study was, I think, like investigator-initiated grant internally. Brigham and Women's, their study, what they published is that they had a lot of different funding from different resources, but also had the hospital help cover it. The Mass General also had the hospital help cover it. And I think even the Toronto group, it was the hospital that had to sort of help cover it because the drug companies were not specifically going to donate it for that setting.
Got it. Okay, thanks. Next question. In countries with universal insurance, are they approving prophylactic or preemptive treatment? And is this being done in other countries?
So it is being done in those countries. So I think a lot of the really novel work has been done from Canada. But I believe that when I asked this question at a meeting, they still had to get funding. So their studies have been funded by their transplant program, internal funding, and they're Canadian NIH. And actually, one of the investigators there, and I said in the email, they have not been able to get DAs ahead of time through insurance. So even in a place with universal health care, they can't get the approval for an infection that doesn't yet exist.
Okay. Next question. Do you have any information on using Mavorette and sofosbuvir/ribavirin for relapse, as has been reported?
So I don't. I mean, when we had our one treatment failure with Zepatier, we then treated them with Zepatier plus sofosbuvir plus ribavirin. Some that have had failures with Mavorite switched over to Vosevi, which is thought to be the sort of biggest gun, which is sofosbuvir, velpatasvir, and foxolaprevir. I think the other question that people have raised about the super treatment failures is, do you have to go old school and try interferon? But that remains to be seen.
Okay. So last question, I think. You mentioned that in your pilot studies you were restricting to genotypes 1 and 4. I guess a couple questions around that. Is it necessary to identify the genotype of the donor in advance in order to decide to proceed? And are there genotype-specific differences in either management or treatment with these transplants?
So that was one where when we started this, we had to use Zepatier, and it was genotype restrictive. That's not really an issue now because I think the drug that you would use would be Mavorite or sofosbuvir, Mavorite or Epclusa. So the genotype is really not an issue. The cure rates are very similar. So I don't think the genotyping of the donor is an issue anymore.
All right, great. So that's all the questions. Thanks very much for a really informative webinar. Thanks to the participants for some really good questions. And I'm going to turn this back over to Deanne.
Thank you. I'd just like to echo your sentiments before we wrap up. So on behalf of the Alliance, thank you to both Dr. Goldberg and Dr. Sung for taking the time to join us today to facilitate such a well-rounded discussion on HCV transplants. And additionally, I'd also like to thank all of our participants for taking the time to join us today, and we look forward to having you join us again in the future. So enjoy the rest of your day, everyone, and thank you again.